Welcome to the latest installment of the AST Journal Club series. Today's AST AJT Journal Club features the AJT article, Pregnancy After Living Kidney Donation, a systematic review of the available evidence and a review of current guidance. The session is hosted jointly by AST's Living Donor and Women's Health Communities of Practice. Our moderators for today's session are Dr. Krista Lentine from St. Louis University School of Medicine and Dr. Anna Rossi from Piedmont Transplant Institute. However, before we begin the main presentation, we do have a few housekeeping notes to help you engage with today's session. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This journal club is being recorded and the archive will be available on the MyAST website 2 to 3 business days after the live session. Please note that all of your lines have been muted so that only the presenters can be heard clearly for the archive recording. If you have a question for our panelists during the Journal Club, we encourage you to participate by using the Q&A button in the Zoom webinar panel. Questions submitted via chat may be missed during the presentation. And if there are any questions we do not have time for at the end, we will either answer them individually offline or we will post the full question with the answer on the website following the Journal Club. Finally, when you log off at the conclusion of today's Journal Club, you will see a link to a short evaluation survey to complete. Please fill out the survey to help us keep our content current and engaging. I will now turn the session over to our moderators, Dr. Lentine and Rossi, to begin our presentation.
Thank you, Brian. Welcome everybody to this AST-wide Journal Club hosted by the Women's Health COP and the Living Donor COP. This is on pregnancy after living kidney donation, a systematic review of the available evidence and a review of the current guidance, presented by Dr. Maria Pippias and Dr. Laura Skinner from the Bristol Medical School in Bristol, UK. I'm Anna Rossi. I'm a transplant nephrologist at the Piedmont Transplant Institute and co-chair of the Women's Health Community of Practice. I'm delighted to moderate this program today along with Krista Lentine from the St. Louis University Transplant Center. Dr. Lentine is chair of the Living Donor Community of Practice and has published extensive work on living kidney donation, including some research and guidance considered in the systematic review that we are about to hear. Dr. Pippias is a clinical lecturer in nephrology and internal medicine at the University of Bristol. She earned her PhD in clinical epidemiology at the European Renal Registry based in Amsterdam in the Netherlands, where she examined kidney transplant outcomes across Europe with a focus on older donor and older recipients. She is coordinating the scientific committee of the European Society for Organ Transplantation in the establishment of the European Living Donor Registry. And she is a member of the International Society of Nephrology's 2022 cohort of emerging leaders. I will now let Dr. Lentine introduce Dr. Skinner.
Thank you so much, Dr. Rossi. So Dr. Laura Skinner is a nephrology and internal medicine trainee at the University of Bristol, embarking on a British Heart Foundation-funded PhD to investigate the role of glomerular microcirculatory dysfunction in the kidney injury of preeclampsia. And along with her translational health sciences work, Dr. Skinner cares for pregnant women with chronic kidney disease and has been involved in recruiting pregnant women to clinical trials investigating hypertensive disorders of pregnancy. Again, on behalf of the Women's Health COP and LDCOP, we're really delighted to host this program. And so welcome, Dr. Pippias and Dr. Skinner.
Well, thank you for the introduction and the invitation to speak here today. These are our conflicts of interest. So to start with, a little background to explain why we felt this paper was needed. As we all know, living kidney donor transplants have a better outcome than deceased donor transplants and are therefore the preferred treatment modality for end-stage kidney disease. This is data from the Collaborative Transplant Study Group showing a 5 percentage point difference in death-censored graft survival by 5 years follow-up in living and deceased donor kidney transplant recipients. As you're all aware, The difficulty with LKD transplants is that we're asking healthy individuals to undergo major surgery with no physical benefit to themselves. And it was long believed that kidney donation did not infer a risk to the health of the living kidney donor. And this is one such study. This is a US UNOS study from 2010, published in JAMA, comparing LKDs with matched cohort from the NHANES 3 cohort. The matched cohort was selected, where possible, to have no contraindications to living donation, and there was a median follow-up time of 6.3 years. As you can see from this Kaplan-Meier curve, the cumulative mortality was 2% in the matched controls and 3% in the living, the survival here was 2% in the live donors and 3% in the matched controls by 12 years follow-up. In the early 2010s, there were some studies published that started reporting an increased risk in donors. So this is a Norwegian study looking at the outcomes of almost 2,000 Caucasian donors with a median follow-up time of 15 years. And they compared them to individuals who would have been deemed fit for donation. And they reported a significant increase in the risk of end-stage kidney disease, cardiovascular, and all-cause mortality beyond the initial 5 to 10 years follow-up. You can see here that the mortality curves begin to diverge at about 10 years follow-up. This is another US-based study, again comparing almost 100,000 LKDs to matched healthy non-donor patients, again from the NHANES 3 cohort. And the median follow-up time here was 7.6 years. However, the group then used the data to estimate the cumulative incidence of end-stage kidney disease at 15 years after donation. The estimated cumulative incidence was 31 per 10,000 in donors and 4 per 10,000 in healthy non-donors. Importantly, the group reported a higher estimated risk in Black and Hispanic donors, with an estimated risk of 75 per 10,000 Black donors versus 24 per 10,000 in Black non-donors. Now, the group then went on to estimate the risk of end-stage kidney disease at the age of 80, and this time they included unmatched, unscreened non-donors. So in other words, the general population. They reported the estimated risk of end-stage kidney disease by the age of 80 to be 326 per 10,000 in the unscreened non-donors, 90 per 10,000 in the donors at the age of 80, and 14 per 10,000 healthy non-donors at the age of 80. So the difference with these later studies showing worse outcomes in LKDs compared to the earlier studies could be due to the choice of the control group and also the length of follow-up. So previously, the outcomes of LKDs were compared to the unscreened general population. However, we know that LKDs are overall healthier than the general population, which is why they're considered eligible for donation. So the earlier studies may have been confounded by selection bias and therefore only reported improved outcomes. However, do bear in mind that first study I showed you by Segev et al., which showing better outcomes in the donors, did include matched controls, where the non-donors in that study were selected as far as possible within the limitations of the data to allow to represent healthy non-donors. Although the follow-up time there was 12 years with that median of 6.3 years. So other limitations to understanding long-term risks to LKDs include the high rates of loss to follow-up and insufficient power to quantify what are really rare events. And you can see that here, the absolute risk in this figure for estimated risk of end-stage kidney disease by 80 years was 90 per 10,000 donors. So why focus on pregnancy outcomes? Well, we know that kidney donation results in a degree of kidney function loss. And this is a systematic review by Garg et al. in KI in 2006. And they determined the long-term effects of donating a kidney. And this is an extract from the abstract that reads, an average of 7 years after donation, the average 24-hour urine protein was 154 milligrams per day, and the average GFR was 86 mil per minute. However, in 8 studies which reported GFR in categories, 12% of the donors developed a GFR between 30 and 59 mil per minute. So why is this important? Well, we know that even the early stages of CKD can be associated with an increased risk of adverse events in pregnancy. So this is an Italian study published in CJSON in 2010. And the group prospectively studied the outcomes of 120 women, pregnant women with CKD, and 267 women with low-risk pregnancies. So this column here are the women with the low-risk pregnancies, and these are the women with CKD with increasing severity of CKD. This is stage 1 and this is stage 2. And you can see here that in these 2 columns with stages 1 and 2 compared to the control group, that there were more frequent complications, including earlier deliveries. At 37 weeks, there were just 5% of deliveries, whereas for CKD stage 1, that jumped to 33%. And there was a lower fetal birth weight, and these babies were born about half a kilo later to stage 1 and stage 2 CKD women. So this brings us on to the aims of our systematic review, of which there were 3. The first aim, by means of a systematic review, was to answer the question, are LKD at an increased risk of pregnancy-induced complications following a donor nephrectomy compared to the risks of pregnancy-induced complications in healthy women who have not undergone a donor nephrectomy? The second aim was to identify guidelines, consensus statements, and expert opinions which included the issue of pregnancy in LKD, and finally, to identify areas which could be addressed in future guidelines focusing on pregnancy in LKD. So how did we go about this? Well, on the 18th of December 2020, we performed a PubMed, Embase, and Cochrane library search for the mesh terms and text words for kidney transplantation, living kidney donor, combined with the mesh terms for pregnancy. All study designs which included LKD with a post-donation pregnancy with any maternal or fetal complication was included, and we included all maternal and fetal outcomes. Non-English language studies and nephrectomies for non-donation causes were excluded. Now, we had planned to perform a meta-analysis, but as you'll see, the lack of consistent outcome definitions and the heterogeneity of the control groups meant that this really was not possible. For the guidelines, consensus statements, and expert opinions, we performed a PubMed search for the mesh terms and text words for guidelines, combined with the mesh terms for kidney transplantation and living kidney donor. And we also searched national renal bodies' websites and a Google search, plus we hand searched the relevant guidelines reference lists. Now, we limited the inclusion of guidelines to those published from 2010 onwards, because you'll see in a moment that the quality of the evidence underpinning earlier guidelines was really quite poor. And where 2 guidelines from the same group had been published, we included the most recent.
This slide displays how we selected our studies. Overall, we included 16 articles published over 35 years from 8 countries. 7 of those articles were excluded as they were case series, reports, or conference abstracts, leaving 9 articles for the bias assessment. After the assessment of bias, we removed 3 of the articles because of a concern about serious bias within those reports. Overall, That left 6 articles to be included in the evidence synthesis. This slide summarises the different comparative groups employed by each of the 6 studies. As you'll note, some of the studies appear twice as they had multiple comparator groups. In the next few slides, I shall talk you through the design of each study. In the study by Rossi et al. In 2009, conducted in Norway, there were 106 pregnancies in 69 post-donation women. These were compared to pre-donation women, of which there were 620 pregnancies, and a group of controls who were not donors, of which there were 21,000 pregnancies obtained from the medical birth registry. Ibrahim et al. In 2009 conducted a study in Minnesota in the US. They compared over 3,000 pregnancies in over 1,000 post-donation women with over 2,000 pregnancies in 846 women prior to donation. They also had a separate group in which they compared 173 pregnancies in 98 LKD who had also had a pregnancy prior to donation. Of note, the Ibrahim study presented a conference abstract in 2017 in which they reviewed pregnancy outcomes of 311 women. 173 of these were those from the 2009 study. Since this was a conference abstract, we've not visited these results further in our discussion. Garg et al. In 2015 conducted a study in Canada in which they compared 131 post-donation pregnancies in 85 LKD to a control which included 788 pregnancies in non-donors obtained from provincial healthcare databases, matched in a 1:6 ratio. Yu et al. In 2018 conducted a study in Korea in which they compared 56 pregnancies in 39 LKD with 370 pregnancies in 186 LKD pre-donation. They also had a matched group of controls that were non-donors and matched in a 10:1 ratio. Davis et al. In 2019 conducted a study in the US where they compared 59 first pregnancies in post-donation women with controls that were healthy non-donors obtained from data warehouse repositories. And again, these were matched in a 1:4 ratio based on age and race. Hong et al. Conducted a study in Hong Kong. They did not have a control group for this. However, they reviewed the outcomes of 17 pregnancies from 11 LKDs. This slide demonstrates the results of our bias assessment. As you'll note, within domain 5, which looked at missing data, the 3 studies conducted before 1997 were all deemed to be seriously at risk of bias, and thus they were excluded from further assessment. Here we show the results with respect to maternal outcomes of preeclampsia. The dark blue bars represent post-LKD pregnancies, whilst the light blue bars represent pre-LKD pregnancies, and the hash bars are non-donor controls. As you'll note, the percentage of women experiencing preeclampsia was higher in post-donation LKD pregnancies. However, this was only significant in 3 of the comparisons. In Garg's study in 2015, 6% of women experienced preeclampsia in a post-donation pregnancy as compared to 3% in matched healthy non-donor controls. In the Rossi study, the incidence was 5.7% in post-donation pregnancies as compared to 2.6% in pre-donation pregnancies. And in Ibrahim's study, in the comparison of the total number of pre-donation pregnancies with the total number of post-donation pregnancies, there was a difference of 5.5% preeclampsia in the post-donation cohort and 0.8% in the pre-donation cohort. With respect to gestational hypertension, in Ibrahim's study in 2009, there was a significant difference with the incidence of gestational hypertension, with 5.7% of post-donation women developing gestational hypertension as compared to 0.6% of pre-donation women. Otherwise, there was no significant difference between the results of the other studies in the incidence of gestational hypertension. Here we display our certainty of evidence table. This is to determine the certainty of the evidence between the following questions. So the first being that the occurrence of preeclampsia was more common in LKD after donation compared to before donation or in the general population. The certainty of evidence for this was low. Similarly, the occurrence of gestation being more common in LKD after donation compared to before donation or in the general population also was deemed to have a low certainty of evidence. Here we display the results with respect to fetal outcomes, and that is babies born prior to 37 weeks. In one of the studies, there was a significant difference in that 7.1% of post-LKD pregnancies were complicated by birth of the neonate at under 37 weeks in the Ibrahim study, as compared to 4% in their pre-LKD group. Between the other studies, there was no significant difference found in the timing of birth of the neonate. This slide demonstrates further results for the fetal outcomes where reported in the studies. So that is of a birth weight that is low, so less than 2,500 grams, infant death at less than 28 days or transfer to a neonatal intensive care unit, and fetal death in utero. What you'll note here is that there were no significant differences in any of the studies between these outcomes. However, when comparing the certainty of evidence for fetal outcomes, both of these questions, so whether the occurrence of delivery prior to 37 weeks was more common in LKD after donation as compared to before donation or in the general population, and similarly the occurrence of a birth weight less than 2,500 grams being more common after donation, the certainty of the evidence for these statements was very low, and this was due to imprecision and inconsistency in both cases. We then went on to review the guidelines, and we identified 8 clinical practice guidelines, 3 consensus statements, 4 expert opinions, which were published between 2010 to 2020. Looking first at the national and international practice guidelines, we note that the majority recommended informing potential liver and kidney donors their increased risk of post-donation pregnancy complications. There was discrepancy in the advice with regards to inquiring about prior pregnancy complications, and also the advice as to whether to seek alternative donors in women who were still wishing to have children post-donation. Some of the guidance specified specific post-pregnancy follow-up. Similarly now, with respect to the consensus statements, 2 out of 3 consensus statements recommended informing donors of their increased risk of post-pregnancy complications. 2 and 3 again recommended inquiring about pre-pregnancy complications and specified post-donation pregnancy follow-up. 1 suggested seeking alternative donors if potential donors may wish to still have children. Having reviewed the evidence, our impression was that donation took living kidney donors from a risk of pregnancy complications lower than that of the general population to a risk comparable to that of the general population, without changes in fetal or neonatal outcomes. In our evaluation of studies, we noted several limitations to be considered when making such conclusions. In most studies, the number of post-donation pregnancies was relatively low. Similarly, the event rates of interest, pregnancy complications, were also occurred relatively rarely. For example, in the before and after design, including the most number of pregnancies, there were 6 cases of gestational hypertension and 6 cases of preeclampsia in 173 pregnancies. Similarly, in the largest matched cohort by Garg et al., there were only 15 cases of preeclampsia or gestational hypertension in 131 pregnancies. We noted that pre-pregnancy parameters for LKDs were not recorded. These are parameters such as hypertension or proteinuria. Further limitations that we identified when performing this review was that of generalizability. We noted that 98% of the study populations were white. The incidence of preeclampsia we know differs between different ethnic groups, and fetal outcomes also differ. This slide shows a figure from the review by Zhang et al. Displaying data from Brahman et al. Essentially, what this shows is the incidence of preeclampsia in a second pregnancy in Black women was higher than that of white women. 38% of Black women versus 18.9% of white women developed preeclampsia. Another figure taken from the paper shows that there are higher rates of complications in Black women versus white women. So Black women had a higher preterm birth weight, lower birth weight infants, higher rates of fetal death, and higher rates of stillbirth. Given that 98% of the women included in the studies in this review were of white ethnicity, we can't be confident that the findings can be applied to non-white women, particularly given this evidence for differing incidence of pregnancy complications between women of different ethnicities. The final set of limitations to be considered when reviewing these studies was that of the study design. I'll move on to this in a moment. What we haven't recognised is that there is a cohort of women who chose not to have a post-LKD pregnancy, and that the characteristics of this group of women are unknown. So moving on to study design. In those studies conducted before 2009, which informed many of the early guidelines, post-donation LKDs were compared to known outcomes in the unscreened general population. As we know, LKDs are not a subset of the population, rather an extensively screened group who are deemed to be at low risk of end-stage kidney disease. Given the overlap between risk factors for complications of pregnancy and those for end-stage kidney disease, comparison of LKD to the general population is unlikely to yield accurate attributable risk. However, the matching performed in some of these studies does go some way to improve the accuracy of comparisons. Similarly, the before and after design aims to provide a more accurate comparison between post-donation LKD pregnancies and pre-donation LKD pregnancies. However, these are useful to assess short-term impacts, although over a longer time, subjects are more likely to develop a confounding condition which may obscure the effects of an intervention, such as increasing BMI post-donation and the impact this would have on post-donation pregnancy risk. As we had mentioned before, the lack of a universal comparator meant that meta-analysis in this assessment was not possible. We reviewed the guidelines and felt that guidance was limited but broadly consistent, that donation takes women to a risk similar to that of the general population, and that women should be informed of this risk. We noted that the more recent guidelines focus on individualizing care In the next few slides, we make some suggestions as to how this could be achieved.
So now on to the final aim of the paper, which is how can the guidance and consent procedure on pregnancy outcomes be improved? So our suggestions were that firstly, we need to personalise pregnancy risks in LKDs, remembering that LKDs are increasingly older and more overweight at the time of donation. Secondly, we need to consider the baseline risk of adverse pregnancy outcomes in the country the LKD will likely give birth in. And finally, we should be providing LKDs with a risk estimation of their absolute risk of hypertensive pregnancy complications, ideally stratified by risk factors such as age, BMI, and ethnicity. Now, I really do appreciate that these are ambitious asks. Where did these recommendations come from? Well, in 2017, the KDIGO Clinical Practice Guideline on the Evaluation and Care of the Living Kidney Donor, which was co-chaired by our moderator today, included this figure, which I think really illustrates the cumulative risks associated with donation. So this figure is for the projected lifetime risk of end-stage kidney disease, but the principles are the same. So imagine this figure referred to hypertensive disorders in pregnancy. So one initially needs to consider the baseline risk, here in blue, which includes things like the age and the race of the woman. Then, on top of the baseline risk, one needs to consider the clinical characteristics of the woman. In this figure here in a sort of apricot-y, peachy colour, called the aggregate risk related to health characteristics such as BMI and smoking status that would contribute to the risk of hypertensive disorders in pregnancy in the absence of donation. If one then adds to these risks the risk of hypertensive complications in pregnancy as a result of nephrectomy, this sort of brownie colour, then one can provide a personalised predicted risk score. And in box 2 of the paper, which we'll come on to, we discuss how we may go about attaining data required to calculate these risk scores. And then point 4 was just mentioning that the risks outlined in 1 and 3 should form part of the LKD consent process. Our next recommendation is that there should be uniformity in inquiring about previous pregnancy-associated complications, such as gestational diabetes, hypertension, and neonatal complications. We recommend that the guidance on LKD pregnancy follow-up is clearer. All LKDs should be risk evaluated and referred to a specialist obstetric care if deemed to be at increased risk. And finally, we recommend that the more recent guidance is utilised, as the older guidance prior to 2015 really does need revision. So on to box 2, our future research priorities and recommendations. Again, an ambitious ask is that LKD registries collect characteristics that would be required to calculate the attributable risk of kidney donation to hypertensive disorders in pregnancy. We recommend that perinatal registries are used to calculate the baseline risk of hypertensive disorders in pregnancy, and this baseline risk in combination with the attributable risk can be used to develop risk prediction models. And ideally, LKD registries should collect data on suitable LKDs that did not proceed to donation. So why do we think this is really important? Well, As I showed at the beginning of this talk, and as we've seen in the results, the lack of a suitable or consistent comparator group is hindering our ability to really understand the long-term risks to kidney donation. If these individuals were followed up in a systematic way, we may be able to answer some of the questions we currently can't answer. A qualitative research to understand the concerns prospective LKDs may have with regards to post-donation pregnancy is really needed. And finally, the long-term health consequences of hypertensive pregnancies in LKDs needs to be established. So in conclusion, donation took LKDs from a risk of pregnancy complications lower than the general population to a risk comparable to the general population without changes in fetal or neonatal outcomes. The guidance was limited, but broadly consistent in advising that women should be informed of that their risk of pregnancy complications is increased post-donation. However, the absolute risk to both mother and baby remain low, and increasing efforts to individualize care are required when counseling potential living kidney donors. So thank you all, and we look forward to some questions and a discussion now.
All right. Well, thank you very much, Dr. Pippias and Dr. Skinner, for a very excellent presentation on a really elegant article. And again, we encourage folks to enter questions into the Q&A. Questions are already coming in. So let's kick off with a question regarding improving the quality of evidence. And Anna and I can note that in the United States, creation of a long-term living donor registry has been a challenge. The Organ Procurement and Transplantation Network collects baseline data on all registered donors, but not on candidates. And you mentioned the importance of going upstream. Further, in the US, follow-up is limited to 2 years and captures only a limited set of outcomes, which actually does not include pregnancy outcomes. I will note that as part of another government contract, the Scientific Registry of Transplant Recipients, I've been co-leading an effort to create a registry called the Living Donor Collective, which is attempting to start at the point when candidates are evaluated at a transplant center with a goal of long-term follow-up and including more diverse outcomes. But we'll also note that participation is voluntary and uptake has been relatively slow. So we were interested if you would tell us about your progress with the European Living Donor Registry, where it stands, the model of participation, what information you're collecting on pregnancy outcomes, and frankly, when data to address some of these knowledge gaps might become available.
Yeah, thanks for the question. So the European Living Donor Registry really is in its infancy, following on from a successful pilot study. And I've only just recently been involved, so there's only so much I can say at this moment with regards to it. But what I can say is that it will have the US model, where it will be a voluntary contribution, and it will be a while before we see any output, really. I guess the data set hasn't been finalized, and I am hoping that these relevant variables are included, although they might not make it to the core data set or the first iteration. I guess one thing, if I could go back on reflection and change that recommendation in the box, I would change it slightly to include one thing. Registries collecting data and storing data is expensive and cumbersome and difficult. And registries are always trying to balance having good quality data without much in the way of missing data versus lots of data. And I guess if I could change that sentence now, I would add a caveat of, or have the ability to link to other registries that may have this data so that you can answer your questions. And that way, if you can link to other registries, you don't have to collect the data yourselves, and you can answer these questions.
Fully agree with that, and that's one thing that we're trying to do in the U.S. model. And I just wanted to elaborate for one of the questions coming in the chat regarding collection of data for folks who don't actually donate, and that is what we're trying to do in the U.S. in the Living Donor Collective. In other words, register all candidates. So everyone who comes to be evaluated will be registered, and then follow those candidates forward, both those who donate as well as those who do not, to provide different control groups. So go on to Dr. Rossi for the next question.
Yeah, so changing gears a little bit, we have a more clinical questions. With the ongoing acceptance of hypertensive living donors, the question is, are we expected to see a higher incidence of complications in association with pregnancy following living donation? And a little bit of a follow-up question to that is, if living kidney donors that get pregnant are considered high risk, who should follow these patients? Should they followed by a dedicated OB professional?
Laura, do you want to take that question?
Yeah, so I think in terms of follow-up of these women, I think it's really important that they're seen by either an obstetric physician or an obstetrician with an interest in maternal medicine, because what we know is that actually it's hypertension, the presence of hypertension and the presence of proteinuria are the key variables that certainly in the CKD cohorts determine pregnancy outcomes. So sort of proteinuria of greater than a gram in 24 hours is associated with an over twofold risk of a baby below the 10th centile for birth weight. And similarly with hypertension going into pregnancy, there's a 16-fold risk of having a baby before 34 weeks. So I think these women being seen prior to pregnancy ideally, but certainly at booking or at the start of their pregnancy is really important to know who needs more intensive review during their pregnancy. So I think, yes, re-review of these women and review of their risk factors is important.
Thank you. Yeah, and I think to build on that, something that is always a challenge is who follows these living donors just in general, because they're healthy, they do well, and they rarely come back to us, right? And so we also need to think about how to educate, the general practitioners and OBGYN, so people know that they can be considered high risk, or teach our donors also when they come for the evaluation. I think that is one of the challenges as well.
And I think that also makes a strong statement of the need for at least basic health care for living donors, and the fact that any living donors could be uninsured is very concerning. If we could, I wanted to change to a slightly different topic. So you had highlighted the limited racial diversity in the studies included in your literature review, and the concern for more severe complications of preeclampsia among Black women in general. Recently, there are some data suggesting associations of renal risk variants in the apolipoprotein or APOL1 gene with preeclampsia, however, with variable results. For example, with one study suggesting that the G1 risk allele may carry risk, and others suggesting that the fetal genotype may matter. In the US, we formed a national consortium looking at APOL1 in the context of organ donation and transplant that is focused on graft outcomes, but may give the opportunity for gathering some of the information related to pregnancy. So based on this, we were wondering if if you feel there may be a role for genetic risk assessment, either for APOL1 or other genes, in predicting the risk of pregnancy outcomes in living donors.
Yeah, thanks for the question. I think this is really interesting work, actually. And so our colleague, Dr. Bailey, has just written the British Transplantation Society guidance recommending that we test APOL1 in living kidney donors of African heritage. So what we're expecting is that there will be more people being tested for APOL1. And so we will have more women who know their APOL1 status. And like you say, really, the story for APOL1 and pregnancy is not yet clear. And there's some really interesting stuff in that, as you were mentioning, sometimes some studies have demonstrated that actually the fetal genotype confers an increased risk of preeclampsia when they're of the G1 genotype. But then there's other studies that have demonstrated that actually the maternal phenotype, if they're a G1, can confer an increased risk. But this is actually of only of early preeclampsia, which in itself is interesting because it suggests that the pathology relates to the placentation stage rather than later stages of pregnancy. So I think, and then the sort of latest on the APOL1 in preeclampsia story is complicated further by the fact that one recent study showed that actually discordance between mother and fetus in APOL1 genotype was more predictive of preeclampsia risk than the genotype themselves. So I'm really interested to kind of follow the story and see where this evolves. But as for determining pregnancy outcomes for women presently, I don't think we have enough information to provide women with a risk interpretation. But I think in years to come, this may well be involved in counselling women, definitely.
And just to add to Laura's point, the UK guidance from the BTS is that if an individual has too high risk alleles, then they should be discouraged from donation.
Do you have a sense of what is the general practice in the UK in terms of who gets tested for APOL1? Is it, people below a specific age? Is it everybody? Do they let the candidate choose?
So the guidance is fairly new, and if somebody is of African or Caribbean heritage, then they are. It's recommended that they are tested.
Okay.
Is there a cutoff? That's a good question. I'm not sure. I don't think the guidelines specifically specify that. And I'm sure, as the case is in the US, within the UK, the practice changes within each transplant centre. So I don't know if that's the case in multiple transplant centres.
Yeah.
Right.
Go ahead, Krista.
Oh, no, I was just going to say, in the ideal sort of risk framework would be if genotype could be considered along with a profile of characteristics. So really, for example, my vision would be adding to the KDIGO risk calculator, which would take into other characteristics, including age, blood pressure, GFR, et cetera. But now to you, Dr. Rossi.
Yeah, we have another question regarding the potential living donor with a history of preeclampsia or eclampsia. So how do you evaluate them? How do you stratify the risk of future hypertension and maybe perhaps future risk of CKD and end-stage kidney disease?
Yeah, so I think it's a nice question, nice to kind of consider the clinical aspects here. My view, but I'm very interested to hear the view of the other panelists, is that having a history of preeclampsia shouldn't alone preclude a lady from donating. I mean, that's my impression from performing this systematic review. And what we know about our healthy donor candidates so far is that presently they've got a normal creatinine clearance, they've got a normal blood pressure, and they're not leaking any protein. So all of those things are very favourable if they were to enter pregnancy with the same parameters. However, obviously they're going to go on to have a nephrectomy. So those parameters may well change. So I think the key here is yes, I think the lady should be able to donate, but it's that follow-up, having donated, as to how her risk then changes. Because if that lady waits 10 years to become pregnant, and in that time she becomes hypertensive and proteinuric, her risk is completely different to a lady that goes on to become pregnant 2 years later, still has a normal blood pressure, has an excellent GFR, and doesn't leak any protein. So I think it's it's kind of, we're going back to the theme that we've alluded to. It's the follow-up of these LKDs that I think is really important, would be my view on things, but I'd be interested to hear the views from the panel.
Yes, I think, I agree with all the things you've been mentioning, and basically consider preeclampsia as another data point. So, yes, they have preeclampsia in their history, but also, what is their BMI? Do they have central obesity? Do they have a family history of hypertension and diabetes maybe? And probably different if they're donating in their very early 20s versus, a little bit later, And so I agree that I don't think we have enough data to say that preeclampsia alone will exclude you as a donor, although I do confess that in general practice, if I have, somebody in their 20s and have their history, I will think it twice, or at least make an effort to make sure that that potential donor understands, the uncertainty. And we have potentially, 60, 70 years, that we're trying to prognosticate what's going to happen.
Fully agree with that. And just to reinforce, we consider the time that the preeclampsia was in relation to donation. So I would kind of, to Dr. Skinner's point, if it was a recent event, that would have more uncertainty and concern than if the preeclampsia were 10 years ago. And we also, not based on any evidence, but we'll do a full ambulatory blood pressure monitoring if that hasn't been done in the donor candidate. But yeah, great clinical point. There's another question that had come up that kind of relates to research recommendation that we'd actually had in the KDIGO guideline, and that pregnancy may be associated with ureteral obstruction and dilation, particularly of the right kidney. And in the KDIGO guideline, we'd included a research recommendation to determine whether the risks and complications vary according to the side of nephrectomy. So I was wondering if you ladies had any data on that, or should that be a consideration? And often I'll talk with that about my surgeon when we're looking at a young woman.
So we did have a look at the data to see if we could find anything based on that, the KDIGO recommendations there. And we found one case report, and that was it. I guess I just, from a research, if I sort of put my research hat on, I just wonder if this is the sort of question that can be answered with real world data. So if data is correctly coded and somebody's coded as having a donor nephrectomy with the side of donation, and they're later coded as having an obstruction, then perhaps we would be able to look at those and try and answer that question with real world data. But I'm interested to see what you think about that.
Fully agree. We need more evidence, and that's why we left it open. But thank you, Dr. Rossi. Do you want to do the next question now? We'll pick the next one.
Let's see. There's some general theme that is occurring, repeating here. So the question is, are there recommendations for follow-up and monitoring during pregnancy post-living donation if the pregnancy occurs early after donation within the first 2 years of follow-up? How should the transplant center monitor and follow up and be involved? I don't know if you have any experience on this. This is very clinical. I personally can say that I have not been involved in the follow-up of any living donors, even if it happened early. It's been OBGYN, but I have to say that is something that we don't commonly encounter. We counsel all our donors to wait at least 6 months post-donation. So I don't know if other transplant centers have been in that situation where they're following pregnant living donors.
I guess I could just say, based on the literature review, we didn't really find anything really in that regard. I know one of the very early papers. I think it was the 1996 paper. One of the donors was pregnant at the time of donation, which was mentioned as a side comment, but that was it. So in terms of research data, I'm not aware of any, or of any anecdotal personal data.
We haven't done anything systematic, but we certainly do encourage our women to stay in touch with us. Our recommendation on is a little longer, so we do generally recommend that women wait about a year to give the remaining kidney time to adapt. But we've had several that I can think of that, for whatever reason, became pregnant early and fortunately did well. But they were kind of reporting back to our coordinator. Not that we had any particular intervention, because they all went fine, but certainly an area of concern. There's another question on a timely topic coming up that we wanted to raise in the last minutes, and that is that based on general population data, some general guidelines like the U.S. Preventative Services Task Force suggest that women with multiple high-risk factors for preeclampsia can consider low-dose aspirin to reduce the risk of preeclampsia. And we did notice that, according to your review, that the UK Renal Association has adopted this guidance for living donors. So we're wondering about your thoughts about extrapolating that evidence to living donors. Should they be considered high risk? Should they all be taking aspirin? Or if not, how soon can we get the answers to better guide that?
Yeah, so I think we recognized when we were going through the evidence that although this is in the guidance, the quality of the evidence of that statement is a 2D grading, so of low quality evidence. But then sort of thinking about how you would obtain the data to obtain a more high quality evidence on this is quite tricky, really. So one way in which we thought you could examine it would be in a sort of observational way, in that those women who were given aspirin in pregnancy, who were LKDs, comparing them to those who weren't, because clearly the practice does differ both in the UK and outside of the UK, I think, at the moment. So I think an observational study in the first instance to compare outcomes would be really interesting. I don't know that we could really conduct a randomized trial. I just don't think that would be feasible. It'd be lovely to do and to know the answer definitively, but I don't think it would actually be feasible. So I think a comparison in an observational cohort would probably be my approach. But in terms of obtaining answers soon, I'm not sure we'd get answers soon from that, but interested to hear what you think as the panel and what you do in the US.
Yes, so no, we've been raising that. I didn't feel also that personally that the evidence was strong enough to recommend that. So I've been thinking about data collection approach as well. I don't know, Anna, have you recommended aspirin to any of your donors?
No, I have not. Yes, I think more data will be nice. Yeah, for sure. Yeah.
Awesome. Well, we are looking at the time, and to respect everyone's time, given that we're just about 2 minutes off, I think we'll conclude that we've reached the end of our program. And again, we really wanted to thank everyone for participating today. Thanks to Dr. Rossi and the WHCOP, as well as excited about the LDCOP being part of this. Thanks to our excellent speakers, and really to the audience for this really robust participation. We tried to answer all the questions. If anything was missed, we will download that, and we can feedback any responses after the program as well. So, and please do complete your evaluation so we can continue to improve these programs. And now we'll pass back to Brian to wrap up our program.
Thank you so much, Dr. Lentine. AST would like to thank Dr. Pippias, Skinner, Lentine, and Rossi, and all of our attendees for today's session. Please remember to complete your evaluation survey and visit myast.org/journal club to view our video archives and register for upcoming journal clubs. To learn more about AST's LDCOP or WHCOP, please visit myast.org/COPS or connect directly to the individual COP hubs. Thank you all again for today's excellent session.